so this is Stacy. So we're going to go over viral hepatitis. We're going to go over pathology, the clinical presentation, as well as the pharm. Okay, so let's start with hepatitis A. So it's a positive single-stranded RNA pico virus. So the transmission is going to be fecal oral. So how we remember that is going to be the vowels, hit your vowels. So hepatitis A and E, the only ones that are vowels, are going to be transmitted fecal oral route. The others are going to be via blood. Incubation period is going to be 2 to 8 weeks. Serology is going to be positive, IgM and IgG. So IgM is acute, where IgG is a past infection or chronic. So I think of like IgM like within the minute. So we know it's acute, where IgG is like a long period of time. So the IgM will increase and then that goes down. And then we increase our IgG as we have like a past infection. There's not a chronic form of this one, unlike the other ones. The treatment is going to be just supportive care, try to help that patient with their diarrhea. And then know that it is important to get the hepatitis A vaccine, especially if you're going to like fast food restaurants or maybe another country. Okay, hepatitis B is going to be a DNA hepatinovirus. So remember the last one we said was hepatitis A, it's an RNA virus. Hepatitis B is DNA. It's going to replicate via reverse transcription. It's circular and partially double-stranded DNA. Transmission is going to be bloodborne sexual vertical from like mother to child. So transmission is, the incubation period is like 1 to 4 months. They usually have symptoms of like sort of like flu-like symptoms to begin with. And then, so they may not even know that they have it. The likelihood of chronic hepatitis depends on age. Infants are at really high risk. Adults are usually at a lower risk. They can develop a carrier state and they can have manifestations such as polyarteritis nodosa, and then important for boards, glomerular disease such as membranous glomerular nephritis or membranous proliferative glomerular nephritis. Treatment is going to be supportive care. The hepatitis B immunoglobulin can be given post-exposure in the unvaccinated, or for people who are vaccinated but they don't get a response. So like you get a titer and you've had all the vaccines and it shows that you still have no immunity to it. They can be given Hep B immunoglobulin to prevent infection. So know that that a vaccine is available, and we all know this because we had to have it for medical school. Okay, histology is going to be a ground glass appearance, and you can kind of see it just kind of looks like, honestly, crushed glass over here on the left, and it's due to that accumulation of hepatitis B surface antigen. And there's going to be portal tract inflammation, and that's really with all chronic hepatitis as well. And you can see that right here in the right picture. Oops. On the right side. Okay, next. So we've got serology, and this is a thing that like really gets tested, and you'll see it on your test and on boards as well. So the first thing that's going to pop positive is going to be the antigen before that we're able to develop antibodies against this infection. So if a surface antigen pops positive, then that means the patient has hepatitis B. If it's not present, then they've not been infected. Chronic infections are present. Like chronically, this will show up positive if they've had it for greater than 6 months as well. So a surface antibody, this is where people get confused. So know the difference between an antigen and antibody. So antibody means I had to build an immunity to it. So if my surface antibody is positive, then that means that I was successfully immunized. So I used to work in a lab, and people get confused all the time. And I would have like physicians and PAs and MPs come and say, what do I order? Like, I want to get the titer, for Hep B because this person had the vaccine. And if they have the vaccine, make sure that you get the hepatitis B surface antibody. So antibody. And it shows that there's effective protection if it's greater than 10. Really, like If yours is at like 15, you still probably aren't really protected. You need to get it like above 100. That would be awesome. Okay. But anyways, back to it. Also, if they have immunity from getting hepatitis B, then that will also be positive. So it's not only for vaccines. E means envelope, but it also means infectious. So if they pop positive, it correlates with viral replication. A high number means they're highly infectious. So in pathoma, if you want to pass the mail, you need an envelope. So so that's how you can remember it. So if it has the E envelope, then you know if you want to pass the mail on to someone, you need envelope. Hep C. So C stands for core. So Hep B core antibody. IgM is the only marker of infection during the window period. And the antigen can't exist because it's in the core of the virion. And then the anti-core antibody IgG is going to be a chronic or resolved infection. So if you're looking for infection, really, if you get a core antibody IgM, IgG, plus all the other stuff. But I look at those and I say, okay, they've got core. That means that they actually acquired hepatitis B, not from the vaccine. Acute Hep B is based on detection of the surface antigen as well as the antibody core IgM. Okay, so serology. So know that window period first is when the surface antigen hasn't been eliminated, but the antibodies haven't been detectable yet. So our IgM is going to be, our IgM for the E for the infectious anti-hepatitis B E will be positive as well as IgM. So this is really important to know. So there's like different ways of looking at it. You can look at the top or the bottom. But know that acute Hep B is going to have that surface antigen, as well as the infectious, that the E envelope antigen as well, and hepatitis B core IgM. Window is going to have the anti-Hep B E, as well as the IgM core antibody. The chronic HBV is going to be, it's going to show that if they're highly infective and they can pass it on because they have the envelope, their hepatitis B E antigen will be positive, but not if they're not infected, passing on the infection. But know that their IgG will be positive because that goes for a long time. And then their surface antigen will be positive as well. If they've recovered or they're immunized, they're like surface antibody, not antigen, antibody will be positive. And if they have recovered and it's not because they've immunized, their infectious antibody will pop up positive, their envelope, and they will have IgG Hep B core that will be positive as well. And those don't pop positive if you have immunization because you didn't actually have the virus and get better from it. You just had a vaccine. So make sure that these, go over these really well because that will 100% be a question. If you have any questions, please ask. Okay, reactivation is going to be diagnosed by an increase of hepatitis B virus DNA. And it can lead to hepatocellular carcinoma. So just know that reactivation is diagnosed by that increase in hepatitis B virus DNA. And so that's what you have to order. Also, like for exam, know that a normal ALTs doesn't mean that there's disease. So if we have a super, super duper high ALTs, that's usually because of like drug, like Tylenol overdose or something like that. Not, or like, or, something, uh, usually Tylenol that could cause, um, your ALTs to be really high. But sometimes people with hepatitis actually have, or like viral hepatitis, actually have normal ALT, AST. So it's important to, not assume, okay, well, that's okay, so I don't need to think about that. So reactivation, increase in HPV DNA. Okay, Hep C is going to be a single-strand RNA flavivirus. Transmission is going to be bloodborne sexual vertical. Perinatal transmission occurs much less frequently than Hep B. Screening is really important because it's asymptomatic. Screen everyone with a risk factor. So I was drawing blood on this patient before med school when I worked at the lab, and this lady said, "Well, I saw this commercial on TV about, the one with the trees. You know what I'm talking about? Can I get tested for that one that has the trees?" I was like, "What in the world is she talking about?" And she was like, "Well, I was like a flower child." And she said, "You're supposed to love everyone." And she's like, "And I may have used some drugs too." This is what she told me. And I figured it out. I was like, "Oh, hepatitis C. Is that what you're asking me?" And she's like, "Yeah, can I get tested for it?" And I was like, "Well, I'm going to have to ask your doctor." I asked the doctor. Anyways, he got really mad, super mad, which is ridiculous. But anyways, he got super mad that like she wanted to get tested for Hep C. And he was like, "There's no way that my patient would have Hep C." And I was like, "Well, this is what she told me." She said she was an IV drug user like in the past. And she had like, you know, she's got a ton of sexual partners back then. And he was like, "Okay, fine then, like she can get tested." Well, she popped positive. She had hepatitis C. So like, don't ever assume, this whole story was, don't ever assume that somebody doesn't have it. She had no symptoms. She had liver tests. Her liver tests were normal, or her AST, ALT were always normal. But she said, "Hey, I saw this commercial and I want to get tested." So like, if they're in that age range, like have a serious conversation with your patient, ask them like, "Have you ever used, needles? Have you, that somebody else has used, like tell me about your sexual partners like in the past." Like it's important to know because you might have a patient, or like, or have you ever had a blood transfusion before the 80s, because they may have hepatitis C and they don't know it. And I know somebody else who died from hepatitis C, and it was from a blood transfusion that she had received a long time ago in the past. So never assume. They're asymptomatic. We're going to screen them. It's easier screening than hepatitis B, but it's hepatitis C antibodies. If the antibodies are positive, it's detectable at 12 weeks. Then we're going to go and test RNA. It's detectable at 2 weeks to diagnose chronic infection. It's chronic in 80% of the patients. So most patients have chronic Hep C if they do get it. And it's going to lead to cirrhosis. Note that Hep C RNA can be positive, but it can, but if you get a negative HCV, like antibodies, it's going to indicate acute infection, because remember, it takes 2 weeks for the RNA to pop positive, but it takes 12 weeks for the antibodies to be positive. And RNA levels don't correlate with disease activity or the timing of infection. So if it's really high, that doesn't mean necessarily that you have more infection or that you just got it, basically. It has the most extrahepatic manifestations of all of the hepatitis viruses, like glomerulonephritis and nephrotic syndrome. And so if you see protein in the urine, that might be a thing, like, oh, let's check for Hep C. It's replicated by its own. There's no vaccine. There's no prophylaxis for HCV. So this is like one of the things that if you do get stuck, that's the scary thing. you like, if you get stuck by a needle, like that would be the thing I would worry about the most, would be hep C. The good thing about it is now there's treatment. The problem with the treatment is it's like 12 weeks and of treatment, it completely gets rid of it. However, it's like $100,000, but that is cheaper than a liver transplant. So remember, HCV RNA positive and the antibodies are negative. That's acute. If they're both positive, it's chronic. The histology is going to be lymphoid follicles in the portal tract, as we see on the left, and then steatosis. So we see these like fat bubbles on the right. Also, most common with hep C is going to be acidophil bodies, which are shown in the arrow. So those like pink, really pink bodies. It's noted in both acute and chronic hepatitis. So I would make sure I know those. Treatment, the genotype is important, and always monitor liver functions. So we have some old drugs, and then we also have new drugs. So pegylated interferon alpha 2A and 2B are going to inhibit protein synthesis. And then ribavirins, one of the big bad things about them is hemolytic anemia. And the patients exposed to these should not conceive children for 6 months. And healthcare workers might get exposed and experience headaches, conjunctivitis, rhinitis, nausea, and rash. So ritonavir is going to be a CYP3A4 inhibitor. And so if we increase we've got the, remember that it's going to like stop CYP. So we're going to increase activity of drug. It increases drug levels when inactivated by CYP3A4. So basically it's just going to like be a booster, for these other drugs. Direct acting antivirals is going to be the cool ones that sort of like completely gets rid of hep C. The problem with these new drugs is that you have to make sure that you don't have hep B, because if you start these drugs, you get rid of your hep C, it's going to reactivate hep B. And remember, we test for reactivation with the DNA testing. So NS3,4A protease inhibitors are going to end with Previr. So second generation, if we see Previr, we're thinking protease inhibitors. They're used in combo due to a lot of resistance, and it expands genotype coverage. So when you are going to treat a patient, you have to get their genotype to make sure that you can get them the right medications. And when it first came out, there was only like one genotype that it worked on, but like now they've increased it as more drugs have come out. So NS5A, so I sort of like see the 5. If I like look at it backwards, it's like an AS. So Asvir is going to be Declasvir, Lediptasvir. So if we see Asvir, think NS5A. NS5B is going to, the B is a Buvir. It's going to be RNA-dependent RNA polymerase inhibitors. And so like Sofosbuvir, make sure that you do not give this with amiodarone. And I would remember that because it is a risk of bradycardia and cardiac arrest if you give them together. Non-nucleoside analogs in PIs are going to be allosteric inhibitors that can be used as an adjunct to some of these other drugs like Desasbuvir. So no, Buvir is going to be NS5B. Asvir, it's like looking at it backwards, NS5A, NS3,4A protease inhibitors are Previrs. Hep D, okay, Hep D is going to be single-strand RNA delta virus, so D for delta, D for hep D. Transmission can be bloodborne, sexual, and vertical, so you can't get it on your own. It's defective, hep D. It is also dependent, and it is a delta virus. So hep D, delta, defective, dependent. It is dependent on hep B. If you do not have hep B, you cannot get hep D. Hep B provides the envelope for Hep D to work. That's why it's defective. It can't work on its own. Hep B prevents Hep D, or Hep B vaccine prevents Hep D. So we don't even have to create a Hep D vaccine because Hep B fixes it because we can't get Hep D without B. So you need to know the difference between co-infection and superinfection. If we get Hep B and D at the same time, they're going to be more symptomatic, but it's going to resolve. Their anti-Hep B core IgM will be high at the time, and they're going to have a low antibody for hepatitis D. Superinfection. So let's say I have Hep B. Later on, a year later, I get Hep D. I'm not going to be asymptomatic. I don't have both at the same time. However, it's going to be chronic. The core IgM is going to be negative because I don't currently have Hep B. However, I'm going to have a super high anti-HDV, and know that that is worse than a co-infection. Hep E is going to be one of the valves. So it is going to be fecal oral transmission. It is a positive single-stranded RNA calcivirus, and Khaleesi. It sort of sounds like Khaleesi. I don't know, Hep E. Transmission, again, fecal oral. Serology is going to be high hepatitis E, IgM if I currently have it, acute, and RNA is positive for 6 months. And if it's positive for 6 months, the RNA, then it's chronic. If it occurs during pregnancy, usually in the last semesters, it is a significant increase for acute liver failure. That is like what I would know about Hep E. I would know Khaleesi, like RNA, and I would know if it occurs in pregnancy, acute liver failure. So like a question could be like, there is a patient has infection, or a pregnant patient has a positive infection with a single-stranded RNA Khaleesi virus. What are they at increased risk for? Acute liver failure. So that makes me like, no, okay, what is single-stranded RNA Khaleesi virus? Okay, Hep E, and then what happens during pregnancy if I get Hep E, acute liver failure. Okay, so this is all of pharmacology right here for hepatitis. Hep C genotype is always important. Make sure you monitor liver function. Make sure that they don't have Hep B when I'm going to give them the new cool treatments for Hep C. Ribavirus, one of the older ones, is toxic because it causes hemolytic anemia, and then the healthcare workers are exposed. If they are exposed, if patients have this, they should not conceive children. Healthcare workers might get headache, conjunctivitis, rhinitis, nausea, rash if they come in contact with this drug. Ritonavir is a strong CYP3/4A inhibitor, so that means that if we give it with another drug, it increases the efficacy of that drug. 100% contact a doctor if you develop fatigue, weakness, loss of appetite, nausea, vomiting, jaundice, light color stools, because you may have serious liver problems. So make sure, but don't stop taking your drugs. This could be that you have Hep B. So make sure that you check your patients for Hep B if you're going to treat them with the cool meds for Hep C. And we've went over those. If you give sofosbuvir, do not give with amiodarone. Okay. Hepatic toxins, central lobular necrosis is common with acetaminophen. I would make sure I know that. Pancreatitis is going to be, it goes along with cystic fibrosis, and make sure that you treat chronic pancreatitis with pancreatic enzymes. Cirrhosis, some of the things that go along with that are ascites, spontaneous bacterial peritonitis, and ammonia and sedative use. Treat cirrhosis, spontaneous bacterial peritonitis. Make sure that you treat it with a third-generation cephalosporin, like cefotaxime, or ceftriaxone. Okay. So now we're going to talk about autoimmune hepatitis. So autoimmune hepatitis is going to be a chronic hepatitis due to a T cell mediated autoimmunity. There's going to be a type 1 and type 2. It's associated with HLA-DRB1 in Caucasians. So usually if they're middle-aged or older, they're going to have a positive asthma, which stands for anti-smooth muscle actin. So old person, type 1, anti-smooth muscle actin. And they'll have also a positive ANA. Type 2 is going to be kids and teens. They're going to have anti-liver kidney microsome 1 that will be positive. So know the difference. So like type 1, so if it's an older patient, they have type 1 anti-smooth muscle actin versus type 2 anti-liver kidney microsome 1. Histology are going to be clusters of plasma cells. So if we see these clusters of plasma cells and you have a patient about like, that has hepatitis and we see these plasma cells, and like other times when we see plasma cells, sort of start thinking about like T-cell immunity, like autoimmunity. And then it asks you like a test that you could test for maybe, and they're older than anti-smooth muscle actin for adults or anti-liver kidney microsome 1 for teens. I just keep repeating this so that you'll remember it. Okay, let's look at some other liver diseases. I included information. She didn't include a whole lot on these. So I don't think that these are like super important for your exam, maybe like the histology pictures, but I included things from Pathoma and from first aid because I do think they're really important for boards. So hemochromatosis, remember it's that extra iron in the body. It's a mutation of HFE gene, usually the C228-2Y. They've got that triad of that bronze diabetes and cirrhosis, and usually sometimes develop a dilated cardiomyopathy. So the labs are going to be increased ferritin. They're going to have decreased iron storage capacity. They'll have increased iron and increased saturation because of a decreased hepcidin. So they're going to have a ton of iron. So just know that, like in their labs. Accumulation of that brown pigment. In a liver biopsy, you're going to see a lot of brown pigment anyways, and that's lipofuscin, but this is not lipofuscin. This is iron deposition. And how we know the difference between the two is it's going to still be positive on Prussian blue stain. So we see that like super dark look on that middle picture. And the treatment is going to be phlebotomy. Okay, Wilson's disease. So I have two stories for this one, but it is an autosomal recessive disorder characterized by accumulation of copper, and the gene is ATP7B. And it's because of, it is a mutation in the hepatocyte copper transporting ATPase, and so that's why the gene is ATP in its name. So the copper is not going to be transported into the bile, and it's not going to be incorporated in the seroplasmin. So presentation is going to be cirrhosis and then neurologic manifestations as they get worse. So they're going to have behavior changes, dementia, chorea, Parkinson's syndromes because of the deposition of copper in the basal ganglia, as well as Kaiser-Fleischer rings in the cornea. So if you see these like brownish coppery colored rings around their iris, as shown at the top and bottom of these pictures, and they have like maybe some speech difficulties, maybe a tremor, and then cirrhosis as well, start thinking Wilson disease. And know that it's not like it's patients before age 40. So these symptoms shouldn't occur anyways. I mean, most likely it's, why is a patient under 40 getting dementia? That's not normal. Their labs are going to be increased urinary copper, and also increased copper on liver biopsy. But the most important lab for this would be a decreased serum seroplasmin, because they're not able to incorporate that copper into the seroplasmin. So their serum seroplasmin is going to be decreased. They're going to have an increased risk of hepatocellular carcinoma as well. And you're going to treat them with a D-penicillamide because it's going to chelate that copper and get it out of their body for them. So here's my story. Here's one of my stories. So I was in psych, And there's this patient, he was 20 something, like I think he's like a little younger than me. He was in his upper 20s, and he was screaming bloody murder, and he was like wanting to fight, and he was like, they said hallucinating. When we went to go talk to him, he wasn't really like hallucinating, uh, but he was mad. But he was like talking a little bit better to us, and he's like, I've just had a hard life and people don't understand me. And he's like, I feel like I'm just like sent to hospitals and they think I'm crazy, and I'm not crazy. Well, he had a history of Wilson disease. I saw that in his chart, and like they didn't know what that was in psych. But I said, you don't need to treat his like psychosis with psych meds. I mean, maybe acutely, but like not long term. I said that he doesn't have a psych disorder. He has these copper depositions on his brain, and that's what's causing this. So we need to get rid of that. And like chelate that copper. So he got treated, not with the penicillamide, but anyways, he got better. And all of his like neurological manifestations went away. His was like that part was reversible. However, um, I have a friend named Logan, and he's also a fourth year. And he told me that he had or somebody that he knew in undergrad. And he said that he showed me pictures, like she was really pretty. And he said that she was smart, and like he remembered, like he didn't know her that well, but he remembered a few things about her. And like, I don't know. I don't exactly know what she wanted to do, but all of it, like she started not being able to walk, and she started not remembering things. And and she was like, she was struggling walking and had to get a wheelchair, and then struggling, she wasn't able to keep up in school, and like eventually had to quit school. And they found out that she had Wilson's disease, but it had progressed so far that they couldn't reverse it. And she recently died. So, all of this to say, like, if you suspect something, you know, I mean, even as a student, it's important to speak up, because you might be changing this patient's life. Like, she might still be here today if somebody found this, that she had this out early. So, I know it's important to study for our exams and know this, all this important stuff, but like, also remember, like, these are real patients with real diseases, and they have to live, their life out and experience these things. So, next slide. Alpha 1 antitrypsin deficiency is an autosomal recessive disorder resulting in the loss of A1A. The most common form is PIZZ, and it's an example of codominance as well. Little first aid knowledge for boards. Lack of antiprotease is going to leave the air sacs and lungs vulnerable to protease-mediated damage. And the presentation is going to be a pan-acinar emphysema in the lower lobes. And possibly it can lead to liver cirrhosis. So basically, we've got all of this like mutant A1AT accumulating in the endoplasmic reticulum of the hepatocytes. So think of like this big old misfolded mess that's stuck in the liver and it can't get out. So in a biopsy, we're going to see this pink DPAS positive globules and hepatocytes. Remember, like any other time in GI that we see PAS positive is going to be Whipple's disease. There's one last test. So this is what this looks like. And so they're going to also have more wrinkles because they're going to have decreased collagen and elastin production. Okay, we're going to go to drug and toxin-induced liver disease. Hepatotoxic drugs are going to be predictable intrinsic or unpredictable idiosyncratic reactions. So what you can remember is hepatitis C. And so hormones, ethanol, valproate, amiodarone, TB drugs, ibuprofen, NSAIDs, Tylenol, and psychotropics and clavulate, and like augmentin, is going to be like amoxicillin, clavulate. That's where that comes from. Are all hepatotoxic drugs. So the most common that I would know, ethanol, Tylenol, and maybe clavulate. Ethanol is going to be the most common hepatotoxic chronic liver failure. And we've got steatohepatitis, accumulation of fatty acids. And acetaminophen is going to be the most common cause. And remember, it causes that central lobular necrosis that's in this picture. And I would like make sure that I knew that. And then clavulate can cause a cholestatic injury. Erythromycin is going to have a drug-induced pure cholestasis. So there's going to be bile plugs present without inflammation or damage. And then a mixed hepatocellular cholestatic injury is going to be similar to acute hepatitis, plus they're going to have bile plugs in the hepatocytes and cliniculi. So I would know that erythromycin can have these bile plugs without inflammation, but then mixed hepatocellular cholestatic injury also has these bile plugs present. Cholestasis is going to be that impaired bile formation and bile flow, and it's due to an intrahepatic or extrahepatic obstruction. And there's going to be defects in the hepatocytes bile secretion. Symptoms are going to be like jaundice and severe itching. They're going to have elevated GGT. The path is going to be plugged in the dilated bile cliniculi ingested by Kupffer cells. And so we can see that right here. And it's kind of like that brown color ingested by peak. Treatment's going to be surgery, and neonatal cause is biliary atresia. Okay, so we're going to stop right there for now.